All right, so jurors, when we were doing scheduling, and I know scheduling has changed a lot in this case, but my main goal is to get this case to you folks by next week, when we all want the case to you by next week. So originally on the 21st, we were either going to do a whole day and then we couldn't do a whole day. And there was all of this back and forth and it was a half a day. And it was because I had something scheduled in this courthouse that was not going to be continued through forces that we weren't aware of. It is going to be continued tomorrow. So in light of that, I would like us, and we will be doing a whole day. I understand that for one of you, that you planned on an earlier start to the weekend or a vacation day or something from the afternoon on. But really, all I'm asking of you is to go from, instead of a 1 o'clock stop, to a 4 o'clock stop. And where I guess 14 of you are able to do that, we're going to do that. So tomorrow will be a full day. Okay, I don't know who I'm inconveniencing, but I apologize for that. Because when I said emergency, an early start for the weekend was not an emergency. All right, could we call the witness back, please?
Trooper, same thing, just be mindful and step up, and you remain under oath.
Thank you. No, it's okay.
All right, Mr. Lally.
Thank you, Your Honor. Good afternoon, sir.
Good afternoon.
So with reference to this case, this investigation, who, if anyone besides you, created any Cellbrite reports or extractions from any of the phones involved in this case?
Other than the AG's office, it was just myself.
And now you had mentioned that there was some deleted material from the defendant's phone from the afternoon of January 29th, 2022. Is that correct?
Yes, that's correct.
And what was that was deleted?
There was some search items that were not there in the phone, but found cookies related to said searches and websites visited.
So as far as search terms or web history, were those the areas that were deleted?
Yes, that's correct.
I have nothing further, Your Honor.
Oh, okay.
Nothing further. Thank you.
Okay, so we brought you back for that, Trooper. Thank you very much.
Thank you.
All right.
Thank you.
Your next witness, Mr. Lally.
Yes, Your Honor. The Commonwealth called Dr. Renee Stonebridge to the stand.
Okay.
If you could please watch your step, face the clip, and raise your right hand.
Do you solemnly swear that the testimony you shall give to the court and the jury in the matter now pending shall be the truth, the whole truth, and nothing but the truth, so help you God? Yes. Thank you.
Hi. So
Afternoon.
once you sit, I'm going to tell you that you have to keep your voice up. We want to keep our air conditioning on. So just if you'd speak loudly into the microphone, that would be great. Yes, thank you. Go ahead, Mr. Lally.
Good afternoon.
Good afternoon.
Could you please state your name and spell your last name for the jury?
Yes, my name is Renee Stonebridge, last name Stonebridge, Stonebridge.
And what do you do for work?
I am employed through the Chief Medical Examiner's Office at Boston as Director of Cardiac and Neuropathology and Medical Examiner.
Now, if I could ask you just a few questions about sort of your educational and work history background, if that's all right.
Yes.
Starting with your bachelor's degree, where did you go and what, if any, area did you receive a degree in?
So I went to SUNY at Stony Brook in New York. I was a double major in biology and Germanic languages and literature. I graduated with a bachelor's of science degree.
After that, I went to the American University of Antigua for medical school, and I graduated with honors, magna cum laude. After that, I did a 4-year combined anatomic and clinical pathology residency program at NYU Winthrop Hospital in Long Island, New York. After that, I did a 1-year forensic pathology fellowship at the Boston office of the chief medical examiner. And after that, I did a 2-year neuropathology fellowship program through Brown University at Rhode Island Hospital.
And doctor, are you board certified?
Yes, I am board certified in anatomic pathology, clinical pathology, forensic pathology, and neuropathology.
And if you could just explain to the jury a little bit about what does board certified mean?
Board certification means that every medical specialty has their own board. So for example, the American Board of Pathology dictates whether or not you can be board certified based on certain criteria. So you have to meet certain criteria, meaning that you have to complete a certain number of surgical specimens, a certain number of autopsies. And then once you meet that criteria, you can take an exam, which if you pass, leads to your board certification.
Now, if I could ask you just a couple, and your board certification is up to date at this point, is that correct?
Yes,
In each of those areas that you just spoke of?
yes.
Now, if I could ask you some general terms as far as if you could define them for the jury. First of all, what is pathology in a general sense?
Pathology is essentially the study of any sort of disease or abnormal state of the body tissues. So anything that can go wrong in the body and any of the body systems is essentially the study of pathology.
And now, starting with anatomic pathology, what is anatomic pathology more specifically?
Anatomic pathology consists of the study of surgical specimens. So for example, if someone goes to the hospital to have a tumor removed, that specimen will go to pathology. The pathologist will look at it, cut it, look at specimens under the microscope, order any ancillary tests if necessary, and then make a diagnosis, which is then conveyed to the clinician. Anatomic pathology also consists of cytopathology, which is looking at individual cells. And then it also consists of autopsy pathology.
And as far as clinical pathology, what does that mean?
Clinical pathology is anything that is lab related in pathology. So if you have to get blood drawn and then the results come back, that is clinical pathology. If there's any sort of blood work that needs to be done, for example, if you're going to have a surgery and they have to cross-match and type you in case of a blood transfusion, that's considered clinical pathology. Also microbiology, so anything infectious. So essentially anything that goes through a lab is clinical pathology.
And what is forensic pathology?
Forensic pathology is the study of autopsies in a medical legal sense. It doesn't necessarily mean that it's always going to be something that is legal. Sometimes it may be just a person who has not seen a doctor in many years, dies at home. There's no physician that is willing to sign a death certificate. So we work on those types of cases, plus anything that is non-natural.
Now, neuropathology, what is that?
Neuropathology is the study of the brain, spinal cord, eyes, muscles, and nerves.
And if you could, just again, in general terms, as far as casework is concerned, related to your work as a director of the neuropathology, can you explain to the jury sort of what it is that you do with respect to neuropathology?
Yes, so my job primarily entails me to be a consultant for the medical examiners. So the medical examiners have a certain set of criteria that they follow in order to determine whether or not a brain needs to be saved for a neuropathologic analysis. So upon following that criteria, if the brain is saved, it gets put into formalin, which essentially fixes the brain so it firms it up, so it makes it easier to analyze. So after the brain has been fixed, I usually let them fix about 2 weeks. Sometimes it could be a little more, a little less, depending on circumstances. I will then look at the brain, take photographs of it from all sides, and then cut the brain, take photographs, document any sort of abnormalities. And then if I feel the need to take sections to look at under the microscope, then I will take those sections. They will be processed through histology. I will look at the slides. Sometimes you may have to add in additional testing, for example, immunohistochemistry, to see if there's anything in particular that you cannot maybe diagnose solely on looking at the histology. And then once that is done, I will issue a report to the medical examiner, and then they use it in terms of determining their cause and manner of death, if necessary.
Now, as far as that formalin process, as far as the solution is concerned, is there a typical time period that the brain would have to be in that solution prior to you examining it or cutting it or any of those other things?
Usually about 2 weeks, give or take maybe a few days here and there, but I usually try to let them fix at least 10 days minimum.
And again, in general terms, with respect to the types of cases that are referred to you, what types of cases are typically referred to you?
So part of the criteria that we use is that any cases for children or babies under the age of 2 years, those always come to me. Also, if there is any cases that have blunt head trauma that may be suspicious or homicidal in nature, those will typically come to me as well. Some of the other cases may be just a difficult neuropathologic entity that a non-neuropath trained medical examiner may not be able to really diagnose. And then sometimes there's cases that are just surprise cases where the medical examiner opens up the head and they see something interesting or abnormal, and they decide to save that case for me to look at further.
Now, with respect to the cases that you do see, at some point did you become involved in analysis or testing of a brain belonging to John O'Keefe?
Yes.
And who was the doctor that was the medical examiner that made that referral in this case?
It was Dr. Irini Scordi-Bello.
And with respect to your analysis here, obviously you looked at the brain. What, if any, other sources of information did you review or did you look at in ultimately formulating your opinion in this case?
So at the time when I was able to cut the brain of Mr. O'Keefe, I had information that was relayed to us from our intake department. So when a case gets called into the medical examiner, it gets taken by the intake department and they're given kind of just a rough summary of the case. I also had the police report, I had the EMS report, I had the medical records from when Mr. O'Keefe was in the hospital. I also had medical records from the primary care physician. I had autopsy photos, and I also had, I believe just refer to my notes here because I had a lot of notes. I also had the inventory and tracking sheets, which are notes created by the medical examiner, and the neuropath request itself.
Now, are you familiar with some terms in relation to injuries that you would observe as far as from a neuropathological perspective, as far as injuries being acute, subacute, or remote?
Yes.
And can you explain to the jury sort of what those are and what those mean?
So it depends on circumstances. Acute generally is something that happened within a very short time frame. So when I refer to something as being acute, I usually refer to that as something that's occurring from the time of an injury to maybe a day or so afterwards. As I said, it's variable dependent on circumstances. Subacute is something that has not happened within the last few minutes, few hours, maybe even a day, and maybe something that is now in the process of healing. And then chronic is usually something that has happened a while ago in the past. You may see some sort of evidence of some type of injury in a chronic state. You may also not see any evidence because it may have completely healed by that point.
And so from your analysis in this case, how did you characterize, in your opinion, from everything that you reviewed as far as the injuries you observed in Mr. O'Keefe's brain?
The injuries I observed were acute injuries, meaning that they probably occurred minutes to hours.
Now, if I could turn your attention to your findings as far as when you conducted your analysis and your testing in this particular case, what, if anything, did you find as far as injuries to Mr. O'Keefe's brain?
So when I look at the brain, what I do is I look at all surfaces from all sides. And one of the things that I look for is anything grossly obvious, meaning anything I can look at the brain and see that there's something there that shouldn't be there. So one of the first things I noticed was a subarachnoid hemorrhage. And subarachnoid hemorrhage is something that occurs when you have bleeding within the leptomeninges. The leptomeninges are a very thin membrane that encase the brain and the spinal cord, and there should not be blood freely floating within the leptomeninges. So if you have a subarachnoid hemorrhage, most of the time, the causes are either a ruptured aneurysm, which is something I would see upon cutting the brain, or some type of trauma. So that was the first finding.
Can I stop you there just for a second? Of those taking notes and for our court reporter, could you spell the type of hemorrhage and the membrane?
Yes. Subarachnoid is subarachnoid. And leptomeninges, leptomeninges.
Thank you very much.
You're welcome.
Now, with regard to anything related to the aneurysm that you indicated that you would have seen, what, if anything, did you see during the course of your review or testing or analysis of Mr. O'Keefe's brain?
So aneurysms are typically seen in the cerebral vessels that sit around the base of the brain. So there's something called the circle of Willis, which is the main arterial supply. It sits around the base of the brain, and it's kind of shaped like a circle that has vessels that come off that extend to other areas of the brain. So typically, if there is an aneurysm that is ruptured, it's going to be located somewhere in one of those vessels. So upon observing those vessels, I did not see any evidence of any aneurysm or any sort of natural disease state that might have led to a rupture in one of these vessels. Also, sometimes these vessels, since they do go deep into the brain, you may only see the rupture upon cutting the brain. And I did not see any evidence of any rupture of any of these vessels anywhere in the brain.
Now, as far as the subarachnoid hemorrhage that you observed, where was that located within the brain, and if you could?
So the subarachnoid hemorrhage was on the frontal poles, which is essentially right here in the front of the brain. So the frontal lobes obviously sit in the front, and then the poles are the very frontmost portion of the brain. So it was on the frontal poles. It was also on the left temporal pole. So the temporal region is right here in the temporal region. And because of the way that the temporal lobe is shaped, it kind of has a little loop right in the front. So it has a pole as well. So it was on the left temporal pole. And then it was also in the left lateral fissure. So you have a frontal pole here. You have the temporal lobe right here. And then the lateral fissure goes kind of in between the temporal and the frontal lobes. So you have the hemorrhage here, and then hemorrhage right there. So it's kind of all concentrated almost in one area. But then there was also hemorrhage of the posterior surface of the right temporal as well. So on this side.
Now, doctor, I'm probably going to butcher this horribly, but just as far as the bilateral unci, are you familiar with that?
Yes. So the unci are the medial portion of the temporal lobes. So the brain is essentially oriented in a way that each hemisphere, the right and left hemisphere, are the same. The unci are the most inner portion of the temporal lobes. So the unci sit just next to the brainstem. So if you have anything that causes herniation of these unci, they start to push inwards onto the brainstem. So say this is the brainstem, here the unci, they start to push in. And because the brain is within the skull is hard, you have no room for any sort of expansion of the brain. If there is herniation, it will start to push in that area because the brainstem turns into the spinal cord and goes out of the skull through the foramen magnum. So you have this hole about this big or so at the base of the skull where the brainstem turns to the spinal cord, then comes out. So that's one of the only areas in which the brain can actually move because it's encased in the hard skull. So if you have herniation, it'll start to push and then push downwards.
Could I ask you to spell
UNCI.
And with reference to this bilateral unsi area, what, if any, herniation did you observe?
So when the unsi herniate, it can be subtle. Sometimes if it's herniated enough, you may see hemorrhages in the brainstem. And this happens because this tissue is now pushing on the brainstem and it's essentially being compressed. So there was herniation noted, and then there was hemorrhage within the brainstem.
Now, if I could ask you, doctor, just to be familiar with the term or medical term known as a contusion,
Yes.
and can you explain just in general terms to the jury what you understand that term to mean?
So a contusion is essentially a bruise. It's blood that's coming out from a blood vessel. It's a blood vessel that has been broken in some way, and now there's blood coming out.
And are you also familiar with another term, part of that term, known as a punctate contusion?
Yes, so punctate is essentially just a way to describe the size of a contusion. When I say punctate, I mean something that's very, very tiny. It almost just like a dot.
And with respect to punctate contusion, what, if anything, did you observe in Mr. O'Keefe's brain, and where was it located?
So there were punctate contusions in the frontal and temporal cortices. So frontal, once again, is the front portion right here. Temporal is kind of right behind it in this area. And the cortex is the gray matter of the brain. So it's a thin strip that kind of just goes around the brain. And then the white matter is underneath all that. So in traumatic injuries, you can see punctate contusions or even larger contusions in the cortex. It usually indicates that the brain has been pushed against something, which is now causing these little blood vessels to rupture, hence seeing the contusions because the blood is no longer contained in the blood vessels.
Now, doctor, with regard to the subarachnoid hemorrhage, is there anything that you're able to do as far as measuring that?
It's hard to measure because it's usually pretty vague. It's not usually something that is a well circumscribed, meaning I could say it starts here and ends here. A lot of times with subarachnoid hemorrhage, because it's sitting in this space that it's not supposed to be in, it can spread. So it may be thicker in one area, thinner in another. So you may have some that may appear just as a very faint hemorrhage, and then some that might be very thick, which you can physically measure. So I usually just give an area where it is and say it's here, it's there, because it's almost like measuring something that has blurred edges. You can't really get a completely accurate measurement.
And what, if anything, were you able to observe or measure with regard to the subarachnoid hemorrhage in the area of the left prefrontal lobe?
So it appeared thicker in that area, meaning that as opposed to it looking just like a faint red color that should not be that color, it was actually thick enough that it was obscuring the underlying brain parenchyma.
If I could turn your attention, doctor, just back for a moment to the punctate contusions that you were testifying about before. As far as your observations of those, was that one or more than one, or how many did you observe?
So there were multiple. There were multiple contusions to the point where it's not something that you can count. I mean, you could count it, but it would probably take a very long time. If it had been something like one or two, three, four, maybe a handful, it would probably be something I would say there are 3 here, 4 there, but there were so many that it didn't serve a purpose to count.
And the number of those, what, if any, significance did that have in regard to your analysis, your observations, or your opinion?
So given that there's multiple, it means that there's enough pressure in the brain that there were many surfaces that were pressing on the bony prominences of the skull, which was leading to a lot of blood vessels rupturing, causing these contusions.
Now, I think you've talked a little bit, but just in general terms, if you could describe for the jury, what is a hemorrhage?
So a hemorrhage is essentially blood that's coming out from a vessel. So it's like a bruise. Hemorrhage, bruise, contusion, they're fairly similar. Some people use them interchangeably, but it's essentially blood that's no longer contained in a blood vessel.
When something is termed medically, based on your training experience as a diffuse hemorrhage, what does that mean?
So diffuse means it's over a very large area. It's not something that's just a tiny little area. You could say, okay, I'm looking at this person's, let's say, liver, and there's a 2 by 2 centimeter hemorrhage sitting right there in the right lobe of the liver. Diffuse would mean there's hemorrhage throughout nearly the entirety of the liver.
Now, with regard to, you made a note as far as there being a diffuse hemorrhage within the pons, P-O-N-S, is that correct?
Yes.
Can you explain to the jury sort of what that means and where is that located within the brain?
So the pons is part of the brainstem. So the brainstem starts right in the middle of the brain, and you have the midbrain, the pons, the medulla, and then it turns into the spinal cord. So the pons is kind of in the middle of the brainstem. And when you have hemorrhage in the pons, in this circumstance, it was because there was the herniation of those oci, which began moving closer and closer towards the pons, pressing on it, causing hemorrhage, because now the tissue is compressed. The blood is not going to be able to flow in and out freely, therefore hemorrhage.
Now, with regard to the totality of what you reviewed in this case in regard to Mr. O'Keefe, would you be able to form any opinions to a reasonable degree of medical certainty in regard to the injuries that you observed to Mr. O'Keefe's brain?
I was able to determine that these are acute traumatic injuries. I know that based on what I observed and in combination with the autopsy findings, that this is due to some type of trauma.
If I could ask, as far as you have certain findings as far as the intraventricular hemorrhage and occipital horns of the lateral ventricles, correct?
Yes.
If you could please explain to the jury what exactly does that mean?
Yes. So the ventricles are almost like a tunnel system of the brain in which the cerebrospinal fluid flows through. So the cerebrospinal fluid serves as a fluid that nourishes the brain. It provides a flow of nutrients, oxygen, things like that. And it starts in the frontal portion of the brain, and then it goes backwards towards the occipital, which is the back. And it also flows downward through the brainstem and then into the spinal cord as well. So the occipital horns of the lateral ventricles are in the back of the head, and having hemorrhage in those areas, and in any area of the ventricular system, is usually indicative of some type of trauma. So there should not be blood freely flowing within the ventricular system.
Now, Dr. Stonebridge, with regard to your findings, you mentioned that your findings were that the injuries were acute and that the injuries were the result of trauma, correct?
Yes.
What, if anything, can you say or can you opine as to the mechanism for those acute traumatic injuries?
It was something that required some type of force, given that there were skull fractures. I can't say what type of force or how much force, but it was definitely something that caused some type of force, which led to the skull fractures and then the subsequent brain findings.
And the brain findings in particular that you made, were those consistent with the fall?
They can be, yes.
Can they also be consistent with being struck by a vehicle and then going to the ground?
Yes, they can be.
Thank you, Doctor. I have no further questions, Your Honor.
You're welcome.
Cross-examination?
You're welcome.
Doctor, thank you very much. You are all set.
Thank you.
Mindful to step down. Thank you.
All right, Mr. Lally, your next witness.
Yes, Your Honor, the Commonwealth called Dr. Irene Scorti Bello to the stand.
Okay.
And Your Honor, as she's coming in, may we approach briefly?
Sure.
So, Madam Court Reporter, what was previously marked SS for identification is now the next exhibit in evidence. Thank you. All right. So are you looking for my instruction now, Mr. Lally?
Yes, please, Your Honor.
All right. So jurors, I gave you a similar instruction before about photographs. So the Commonwealth intends to introduce into evidence through the next witness certain photographs showing Mr. O'Keefe post-mortem. You'll have those photographs with you in connection with this case. I understand that some of them will be shown up on the screen, and that's why I want to sort of give you a warning that that will happen. When they come to you as exhibits, they'll be placed in an envelope. You can, look at them briefly. They'll be covered, is what I'm saying to you. So the photographs are not pleasant. They can be described as graphic. And I instruct you that your verdict must not in any way be influenced by the fact that these photographs will be unpleasant, perhaps sad and graphic. The defendant's entitled to a verdict based solely on the evidence and not one based on pity or sympathy for Mr. O'Keefe, which might be occasioned by the photographs. So please consider those photographs only as they draw your attention to a clinical, medical status or to the nature of Mr. O'Keefe's injury or to the nature of the incident itself. Okay. All right. Now your next witness, please, Mr. Lally.
Yes, Your Honor.
Be mindful to step up. You could remain standing.
Oh, gosh. Do you solemnly swear that the testimony you shall give to the court and the jury in the matter now pending shall be the truth, the whole truth, and nothing but the truth, so help you God? I do. Thank you.
Good afternoon, doctor.
Good afternoon.
right, Mr. Lally, whenever you're ready.
Good afternoon, Doctor.
Good afternoon.
Could you please state your name and spell your last name for the jury?
My name is Irene Scordibello. My last name is spelled Scordi-Bello.
And how are you employed, ma'am?
I am employed as a medical examiner.
And for whom are you employed?
I'm employed by the Office of the Chief Medical Examiner for the Commonwealth of Massachusetts.
And how long has it been that you've been medical examiner for the Office of the Chief Medical Examiner in Massachusetts?
I have been with OCME in Massachusetts since December of 2016.
Now, ma'am, if I could take you back and just ask you a few questions regarding your educational background, work history a little bit prior to working at the OCME in Massachusetts. If I could start with your undergraduate work, as far as where did you go and what, if anything, did you receive a degree?
I completed a bachelor's degree in microbiology at the University of California.
And after receiving that degree, where did you go from?
I went on to the University of Miami, where I completed my doctorate degree in immunology. And following that, I moved up to New York City, where I went to medical school. I completed 4 years of medical school at the Mount Sinai School of Medicine. And following medical school, I completed 3 years of pathology residency at the Mount Sinai Hospital.
And then following your residency at Mount Sinai, where did you go from there?
And from there, I went downtown in New York City and I completed a 1-year fellowship in forensic pathology at the Office of the Chief Medical Examiner for the City of New York.
And following that 1-year fellowship there, where did you go from there?
I worked in New York City until 2016 when I moved here to Massachusetts.
Now, are you board certified?
Yes, I am.
And what are you board certified in?
I'm board certified in anatomic pathology and forensic pathology.
And if you could explain to the jury just briefly, what does it mean to be board certified and sort of what is entailed in that process?
Board certification is actually a voluntary process that a physician decides to go through. It involves completing an accredited program in the specialty of choice. In my case, it was pathology and forensic pathology, and then completing a number of requirements as well as taking and successfully passing exams, and then being able to say that you're board certified.
And is that certification at this time, is that up to date?
Yes.
Now, with regard to the time that you've been working as a forensic pathologist, are there any organizations that you belong to in relation to your work in that field?
Yes, I am a member of the National Association of Medical Examiners.
And that's an acronym as far as name.
Name.
Is that correct?
Yes.
Now, with respect to that time frame as well, what, if any, experience do you have in regard to teaching the areas related to your field?
I have always been interested in teaching. I started teaching as a pathology resident, teaching other residents and medical students. And during my time in New York City, I enjoyed teaching medical students and residents. We had a very active education program in New York City. So I've always been involved with teaching both pathology and forensic pathology.
Now, to those terms themselves, if I could ask you briefly just to describe to the jury as far as pathology in general sense, what does pathology mean?
Pathology is a specialty of medicine, and pathology looks at disease processes and as well as trauma and the effect they have on the human body.
And what is forensic pathology?
Forensic pathology looks at disease processes and injuries in the human body and tries to determine the cause of death in deceased individuals.
And as far as anatomic pathology, what exactly is it?
Anatomic pathology, as opposed to clinical pathology, is has to do with any organ that is in the body, versus clinical pathology that deals with fluids and blood analysis and things like that. So anatomic pathology, a lot of anatomic pathologists are surgical pathologists. That's another term that you will hear. These are pathologists in the hospital that look at tissues under the microscope, and they come to a diagnosis, whether something is benign or malignant. And forensic pathology takes anatomic pathology to another step, to another level, by looking at the whole body and trying to determine the cause of death instead of organ specific. Instead of just looking at one organ, forensic pathology looks at the whole body.
Now, you're also familiar through your work and training experience in regard to forensic pathology with a term called autopsy.
Yes.
And is that something that typically you would do in the case of sort of your investigation and your analysis in regard to pathological analysis when it came to a body or a patient that comes in?
Yes, an autopsy is a procedure that we do to determine the cause and manner of death.
And so, doctor, with respect to an autopsy, may be a term that's pretty well understood, but if you could explain in general terms as far as when a body or a patient comes in to the OCME, as far as what is an autopsy, what is involved in it, and sort of what does that consist of?
Yes. When a case, a death is first reported to the medical examiner's office, we make a determination as to whether that death falls under our jurisdiction. Cases that fall under the jurisdiction of the medical examiner include all violent deaths, all deaths that are due to not natural causes, all accidents, intoxications, deaths of babies and children, and deaths in individuals that were not under the care of a physician when the death occurred. So once a case is accepted and it falls under our jurisdiction, it is given a numerical number, and then the body is transported from either the location of the death or the hospital to our facility. Our facilities. We have 3 facilities in the state of Massachusetts. Once the body comes to our facility, then there are a number of steps that are taken. The body is processed. What that means is that there pictures are taken, a weight is taken, a height is taken. Everything is input into our computer system, and then a determination is made as to whether an autopsy is required in order for us to determine the cause and manner of death. If the answer is yes, then we proceed with the autopsy.
Now, as far as an autopsy is concerned, there are 2 sort of primary components of that as far as an external examination and an internal examination. Is that correct?
Yes.
And can you describe to the jury, again, in general terms, sort of what the process is in reference to both external and internal?
Yes. So the autopsy or the postmortem examination has 2 main parts. The first one is the external exam, and it is basically what it sounds like. We do a very thorough exam of the outside of the body. We document physical characteristics, eye color, hair color. We document any scars or tattoos that may be on the body. We take pictures, we make notes, we look for any signs of disease and any signs of injury. All that is, as I mentioned, documented. And once we're, during the external examination, sometimes we will take evidence. We will collect hair and nails from the body if we think that that is necessary or warranted. And once the external examination is done, then we proceed to the internal examination. That involves making surgical type cuts on the body, what's known as the Y incision that goes from shoulder to shoulder and down the middle of the body, and the organs of the neck, the chest, the abdomen are examined thoroughly, again, looking for and documenting signs of disease or signs of injury. We do the same thing with the head. The head is open, the brain is removed, and we document any disease or injury.
Now, turning your attention to January 31st, 2022, did you have occasion to perform an autopsy in regard to a patient or a body of John O'Keefe?
I did.
And do you recall which of, you mentioned there were 3 different offices of the chief medical examiner within the state of Massachusetts, correct?
Yes, it was in the Cape Cod office.
Is that the office that you typically work out of?
No, that's not the office I typically work out of. My permanent position is in the Westfield office in Western Massachusetts. I was covering the office that day because we were short-staffed.
And in the reference to the autopsy that you performed with regard to Mr. O'Keefe, was that in conformity with what you were speaking about just before, generally as far as how you conduct autopsies?
Yes.
Now, during the course of the autopsy that you performed in reference to Mr. O'Keefe, during the course of the external examination, what, if anything, did you note in reference to that external examination of Mr. O'Keefe?
First, I noted that there was evidence of medical intervention. Mr. O'Keefe's body was transported to our facility from the hospital, and he had evidence of attempted resuscitation. After I documented that, I proceeded to document some injuries that I saw on Mr. O'Keefe's body.
And before we turn to that, if I could just ask you a couple more general questions. You've made some mention earlier in your testimony as far as the cause and manner of death in general. That's 2 things that you're trying to determine during any sort of forensic pathological examination, correct?
Yes.
And what I'm going to ask you first is just in reference to manner of death. Can you describe for the jury sort of what are the different types of manner of death, and how are they sort of classified from a perspective from your office?
Okay. Yes. So the manner of death are the circumstances that led to the cause of death. The cause of death being the disease or the injury that initiated the sequence that led to the fatal events. So the manner of death is circumstance dependent. There are 5 general manners of death, or 5 umbrellas. The first one is natural. When we determine a manner of death to be natural, it means that the death was caused exclusively by natural disease. That would be heart disease, liver disease, cancer, aging, Alzheimer's, dementia, etc. The second manner of death is accident. That means that the cause of death was due to an injury or due to an intoxication, either a physical injury or a chemical injury. But the circumstances show little or no evidence that intoxication or that injury was intentional. So most motor vehicle accidents, most drug overdoses, most elderly falls are classified as accidents. The fatal outcome was not intentional. Homicide is a manner of death when there is injury inflicted by another person, but there is evidence that there was intent to cause fear, harm, or death to the other individual. And suicide is due to either an injury or an intoxication. And again, the circumstances and the evidence suggest or point strongly to the fact that that was a self-inflicted, intentional act on behalf of the person with the intent to cause harm to themselves or cause death to themselves. So most hangings, intentional overdoses by prescription medications are classified as suicides. And then we have, I'm sorry, and then we have one more manner that we call undetermined. Some jurisdictions, they call it could not be determined. That means that evidence pointing towards one set of circumstances or one manner is no more compelling than evidence pointing towards another manner of death. So if we don't have enough information to know whether something, or to be able to determine the circumstances, then we are left with an undetermined manner of death.
Now, am I correct in stating that the cause of death is something that's more like a medical determination? Is that correct?
Yes, the cause,
So watch the leading questions, Mr. Riley. It's sustained.
How would you characterize the determination that you make in regard to a cause of death?
the cause of death is based on my findings at the time of autopsy, along with any medical information that I may have on that deceased individual.
Now, as far as the manner of death, how are you making that determination?
The manner of death, as I mentioned, is circumstance dependent. I make that determination based on investigative information that is provided to me by law enforcement, by the people who did the investigation.
And what, if any, legal determination are you making as far as when you classify something as either of those 5 categories in a manner of death?
I am not making a legal determination. I'm making a medical determination.
And so as far as the medical determination is manner of death, specifically when I'm talking about something that could be ruled or listed as manner of death as accident, is that, what if any determination are you making as far as that is concerned?
I'm making the determination that the information that I have either shows no evidence or very little evidence that the injury that led to the cause of death was intentional. So I don't have any information to suggest that that was an intentional act.
And am I correct in saying that routinely people charged with, say, motor vehicle homicides, it gets classified as a manner of death as accident, correct?
Objection. Sustained.
Mayor Pro Tem.
Yes.
Doctor, I'm showing you the documents, ask you to review it, look up when we finish.
Yes,
And do you recognize that document, Doctor?
I do.
And what do you recognize that to be?
This is a copy of the death certificate for Mr. John O'Keefe.
That's signed by yourself, is that correct?
Correct.
And as far as the listing related to cause of death, what did you list as cause of death on Mr. O'Keefe with regard to his death certificate?
Cause of death was blunt impact injuries of head and hypothermia.
And with reference to manner of death, what, if anything, did you list on Mr. O'Keefe's death certificate in relation to manner of death?
I listed could not be determined.
And as far as that listing for could not be determined, if you could explain to the jury why it was that you have that listed as a manner of death with relation to Mr. O'Keefe.
Again, the cause of death is something that I can determine by the autopsy. I did the autopsy on Mr. O'Keefe and determined that he had injuries to his head as well as signs of hypothermia. So the combination of those two was the cause of death. The manner of death has to do with the circumstances under which Mr. O'Keefe sustained those injuries. And I did not have enough information to be able to determine whether those injuries were accidental or not. And so my manner of death was undetermined or could not be determined.
And just from the spectrum that you had just talked about, sort of the 5 different manners of death, fair to say that you did not determine that this was either suicides or natural causes, correct?
Correct.
And so as far as your determination of the manner of death being could not be determined, which of the two were you sort of in between?
The two manners of death that remain are accident and homicide.
Your Honor, may I approach?
Yes.
I want to seek to introduce in a minute the next exhibit. Now, Dr. Scortibello, you had made reference as far as cause of death being a blunt force injury. Is that correct?
Correct.
At least one of the contributing causes. If you could explain to the jury sort of what you understand that to mean as far as what is a blunt force injury.
Blunt force injuries are caused by any blunt object. That is a very big category of objects. A microphone could be a blunt object. This bottle, if heavy enough, could be a blunt object. The ground can be a blunt object. So anything that doesn't have a sharp edge or a razor edge, not a knife, not a scalpel, is a blunt object. Blunt impact injuries are categorized into contusions, which are bruises, abrasions, which are scratches, fractures, which are a break in the bone, and lacerations, which are tears in the skin. So when we say blunt impact injuries, right arm, I noted the abrasions on his posterior right arm and forearm. Those ranged from 3 millimeters to up to 7 centimeters. I noted 2 red contusions on the dorsal aspect of the right hand. Again, that's the back of the hand. A faint abrasion, a faint scratch on the dorsal aspect of the left hand, and a small 0.5 centimeter abrasion on his right lateral knee, on the side of his knee, on the right side.
Now, I think you've defined it fairly well so far, but I'm just going to ask you, just for delineation purposes, if you could explain to the jury sort of what is the difference between an abrasion versus a contusion versus a laceration.
Okay. An abrasion is a scrape. It's a scrape of the superficial layers of the skin. A contusion is a bruise. So if I hit myself hard enough on my nightstand, and I break blood vessels under the skin, then I can end up with a bruise or a contusion. A laceration is a tear, not necessarily a cut. There's a distinction between a cut and a tear. A tear in the skin is due to a blunt object, maybe the corner of the nightstand that's sharp enough to tear my skin, but not so sharp as a blade that would actually cut the skin smoothly. So we differentiate between lacerations and cuts because cuts are due to sharp objects, lacerations are due to blunt objects. And fractures are basically a break in the bone, again, due to blunt trauma.
Are you familiar with what is termed as an incised wound?
I'm sorry, I didn't hear you.
Incised, I-N-C-I.
Incised, yes.
If you could explain the difference between sort of the mechanism and sort of what you observe between a laceration and an incised wound.
Yes, so an incised wound is what I previously called a cut. So the analogy I like to give is if you have a loaf of bread and you're trying to cut the bread. If you take a very good bread knife, sharp knife, you will be able to smoothly cut the bread. If you take a hammer, which is a blunt object, and you try to cut the bread, you're going to shred it up. So an incised wound is a smooth cut. Knives, razors will cause incised wounds on the skin. a blunt object will cause a laceration. It will break the skin and the edges will not be uniform and there might even be some bruising around it.
Now, with respect to the injuries that you talked about as far as the abrasions on Mr. O'Keefe's right arm, how was that located in reference to sort of the circumference of the arm? And what I'm asking there is, was it on top, on the bottom, or everywhere?
I described them as being on the posterior right arm and forearm. So when we examine a body, we examine the body in what's known as the anatomic position, which is the body on the table with the palms upwards. And so the posterior right arm and forearm would be what would be facing the table as the body is laying on the table, the backside of the arm and the forearm.
So the opposite of posterior would be what?
Would be anterior, and it would be this area right here that points up.
And as far
Or
as
forward.
the anterior of Mr. O'Keefe's right arm, what, if anything, did you observe as far as injuries there?
I noted in my diagrams and my charts that they were mostly on the posterior right arm and forearm.
Now, Dr. Squarty-Bell, if I could turn your attention to the internal examination as far as the injuries that you observed there, what, if anything, did you observe during the course of your internal examination of Mr. O'Keefe?
Okay, the internal examination, I will start with the head. Once the skull was open and the head was examined, I noted that there were skull fractures in Mr. O'Keefe's skull, both in the back and the front aspect of his skull. I noted that there was recent subdural hemorrhage. That is blood that is under the dura, and the dura is a very tough protective cover that sits over the brain. I noted that there was subarachnoid hemorrhage. That's hemorrhage that is directly on top of the brain under the leptomeninges, which is a very thin membrane that covers the brain. And at that point, I removed the brain and I, instead of examining it right then and there, I saved it in a special solution and I sent it to our office in Boston for our neuropathologist to fully examine.
And is it your understanding that a neuropathologist ultimately conducted a fuller examination of Mr. O'Keefe's brain?
Yes,
And who was that neuropathologist within your office?
Dr. Stonebridge.
Now, with reference to the head, as far as the skull, you indicated that there were fractures as in plural, correct?
Yes.
And with reference to the fractures, what, if any, relationship did you know between the fractures that you observed and the laceration to the back of Mr. O'Keefe's head that you spoke about in your external examination?
So the laceration on the scalp that I observed was overlying the area of the skull that appeared to be fractured, or at least appeared that the fractures were originating from that point of impact and extending into the rest of the skull.
Now, one of anything as far as your observations of the skull on that point in the, I'm sorry, which part of the skull was the originating fracture?
This would be on the back of the skull, slightly right of midline.
Is that the medical term that that's referred to as?
I'm sorry?
Is there a medical term that that's referred to as far as the right rear sort of?
It's the right occipital.
And what, if anything, led you to that opinion that that was sort of the originating source of the multiple fractures in the skull that you observed?
Again, observing or looking at the skull fractures and their pattern, there appeared to be a central point with fractures radiating or originating from that central point and going into other parts of the skull.
Now, in reference to that laceration in the area of the originating fracture in the back of the skull, what, if anything, did you determine in regard to impact in regard to that area of the head?
Well, the laceration along with, so the tear in the skin along with the scrape, because they were adjacent, are both evidence of blunt impact. So I knew at that point that Mr. O'Keefe's head had come in contact with a blunt object.
Would that be sort of the point of impact between the blunt object and Mr. O'Keefe's head?
Right.
Now, with reference to the fractures that you would observed, how extensive were the fractures that you observed, the multiple ones?
Well, there were multiple fractures. So by definition, multiple fractures in multiple chambers or parts of the skull. So I would say they were extensive.
Have a moment, Your Honor.
Yes.
Now, when you're conducting this internal examination, is there sort of a division of the body that you're doing as far as what you're examining and in what order and sort of things that you're looking at from the internal examination?
Well, we examine everything, and usually we start in the external examination, we start from the head and work our way down. During the internal examination, we're doing two things at the same time sometimes. And so I start with the chest, move to the abdomen, and then the pelvis, while at the same time, we're working on the head.
All right, I'm going to pause you there for a minute. We're going to take a short recess and we'll be back.
Doctor, you can step down if you'd like to. You don't have to, but you can step down if you want to, and I'd ask that you just call over the jurors.
I'll just, thank you.
I'll see counsel at sidebar.
All rise for the court, please.
You are muted.
be seated, go back to that.
All right, Mr. Lally?
Thank you. Now, doctor, as far as the internal examination was concerned with regard to Mr. O'Keefe, starting with his stomach, what, if anything, did you observe of any significance in that area?
I observed that there were some small hemorrhages, small areas of bleeding in Mr. O'Keefe's stomach.
And are those described in medical literature as a specific type of spot?
They have a name. They're called Wisniewski spots. Wischnewski. And they have been associated with cases of hypothermia.
And how so? How have they been associated with cases of hypothermia?
They have been seen in cases of hypothermia. It's one of the findings that supports the diagnosis of hypothermia. They are not always there, and their presence doesn't definitively diagnose hypothermia, but they are one of the findings that, if present, suggest the diagnosis of hypothermia.
And based on your training and experience, based on other types of literature that you've reviewed in regard to hypothermia, what is, as far as these Wisniewski spots, and thank you very much for saying that until after you had said it. With regard to that, what if anything does it say as far as the causality of that, or how that occurs or is related to hypothermia?
We don't really know the pathophysiology of these spots. There have been various hypotheses. People have suggested that they are a response to stress. Some people have suggested that hypothermia increases secretion of acid in the stomach, and that leads to these spots, but their exact pathophysiology is still under investigation.
Now, in addition to these areas of small hemorrhage in Mr. O'Keefe's stomach, what, if anything, did you observe in the pancreas?
In the pancreas, I again observed some more diffuse hemorrhage of the pancreas and the tissues around it.
And same question with regard to the spots and the hemorrhages you observed in the stomach. What, if any, relationship do the hemorrhages or the bleeding in the pancreas have in relation to hypothermia?
Again, it's one of the findings that, if present, should alert the medical examiner to consider the possibility of hypothermia.
And as far as the observations that you made, as far as the hemorrhages in the stomach area of Mr. O'Keefe and the hemorrhages in the pancreatic area of Mr. O'Keefe, the sort of juxtaposition of those, what, if any, significance did that have in regard to your hypothermic diagnosis?
When the case was called into our office and when we accepted the case, it was reported to us that this was an individual that was found in the snow, covered with snow, and it appeared that he may have been there for a period of time. So one of the questions for me as a medical examiner is to determine whether there are any signs of hypothermia in addition to what I had already observed, which was the blunt impact injuries. And the combination of the gastric, the stomach, and the pancreatic hemorrhages strongly suggested, given the circumstances and how the body was found, that hypothermia did in fact play a role in his death.
Now, probably should have asked this first as a precursor, but when you use the term hypothermia, what do you understand? What does hypothermia mean from a medical diagnostic perspective?
right? Hypothermia is a term used to describe low body temperature, by definition, 35 degrees centigrade or below. And there are levels of hypothermia, from mild hypothermia to severe hypothermia. It just basically means the body is losing heat faster than it can generate it.
And typically, what would be the sort of core body temperature that would determine someone as hypothermic versus not?
We're usually at 98 degrees or 37 degrees centigrade. So anything higher than that is considered a fever or hyperthermia. Anything lower than 35 degrees centigrade or 95 degrees Fahrenheit is considered hypothermia.
Now, if you could explain to the jury sort of a little bit about the type of diagnosis that is involved in hypothermia, and sort of what other sort of types of information you would be looking at in order to make that diagnosis.
Hypothermia is a difficult diagnosis to make, and sometimes it's a diagnosis of exclusion, meaning that all other possible causes of death have been ruled out and you're left with hypothermia. So a body that is found in the snow or in a cold environment and has a core body temperature of 85 degrees and is unresponsive or asystolic, meaning that there is no heart activity, could be a hypothermic death, or it could not be a hypothermic death. And it's up to us to determine by doing the autopsy what other factors are at play. So the example I like to give is a person with severe coronary artery disease goes out to shovel their driveway, suffers a heart attack, and drops to the ground and is dead within seconds. And no one discovers their body for a few hours during the storm. When they're found, they're asystolic, their core body temperature is 80 degrees. But the autopsy shows another reason for their death. It shows a massive heart attack, which is what killed them. They just happened to be outside after they died and they lost heat and their body temperature dropped. Doesn't mean they died from hypothermia. However, if you take a person, an elderly person, or any person, an intoxicated person, a person who is intoxicated with drugs, that goes out into bad weather, gets confused, loses their direction, isn't able to get to shelter, and they die, their body temperature starts to drop, they get more disoriented, they get more confused, their organ systems start to shut down, and eventually they die from hypothermia. So that person will also be found in the snow with a core body temperature of 80, 85 degrees. But when we do the autopsy, if we see those gastric hemorrhages, if we see that bleeding in the stomach, if we see the bleeding in the pancreas, if we look at their toxicology and we see that they were intoxicated with multiple substances, then we can determine, or we can opine, that the cause of death was at least partly due to the hypothermia, because they were still alive when they started losing heat, as opposed to someone who had the heart attack and was already dead when they started losing heat from the body.
Doctor, when coming to your opinion in relation to the cause of death of Mr. O'Keefe, in addition to your autopsy, your internal, your external examination, what, if any, other materials were you provided, and what, if any, other materials did you review in relation?
I was provided with a police report, an investigative report. I was provided with some of his prior medical records. I was provided with records from the hospital where he was first taken by emergency medical personnel. And during the course of the autopsy, of course, I didn't mention this. We also, during the autopsy, collect fluids from the body that are sent to the lab for toxicologic analysis. And after a few weeks after the autopsy, we get a report from the toxicology lab. And in this case, I looked at the toxicology report. As I mentioned, all the information from the investigators, the autopsy findings, the neuropathology findings, and came to a conclusion as to the cause.
Now, as part of the documentation that you received from the investigators, did that include photographs of the scene as well?
Yes, it did, some photographs.
Turning back to the toxicological findings that you received, what, if any, indication did those findings have, or did they indicate in regard to blood alcohol concentration with regard to Mr. O'Keefe?
Mr. O'Keefe had alcohol in his system, and I do believe, I don't have the toxicology in front of me, but in his blood at the time of autopsy, the level was 0.21 grams per deciliter.
Now, contained within those toxicology findings, there's also something listed as a vitreous humor. Is that correct?
Yes.
And can you explain to the jury sort of what that is, where that sample is taken from, and why?
Yeah, that sample, the vitreous humor, is taken from the back chamber of the eye. It's one of the routine samples that we take in addition to blood from the body and urine. And it's, again, used to look for the presence of different drugs. In cases of alcohol intoxication, sometimes we will get a value for the vitreous, and sometimes that value might not be exactly the same as the value that we get for the blood. It gives us an idea of where in the curve of alcohol metabolism, the individual is.
And so, based on sort of the disparity between the vitreous humor level and the, I'm sorry, I may not have asked, what was the level in the vitreous humor?
I believe it was higher. Sorry, I just have to find it. I think it was 0.26. I'm sorry, I can't find it in his notes. I don't know if you have the,
John, may I approach?
yes.
Oh, yeah, copy of the toxicology report.
Yes. It was 0.28.
Now, doctor, with respect to the disparity between what was contained as the BAC and the vitreous humor versus the other number from his blood, what, if anything, does that indicate to you as far, or what, if anything, do you take from it?
That suggests that the level in Mr. O'Keefe's blood had been higher than 0.21, and that's reflected by the 0.28 that was in the vitreous. The vitreous metabolism of alcohol lags. It's a little slower, lags behind that of the blood and the circulation. The alcohol is metabolized in the liver, but the fact that it is higher in the vitreous suggests that the level in the blood was also higher at some point prior.
So at some point, whenever Mr. O'Keefe died, his level of alcohol was on the decrease. Is that fair to say?
Correct.
Now, with respect to, you mentioned that you had reviewed the EMS reports for Mr. O'Keefe as well as his medical records from Good Samaritan. Is that correct?
Correct.
And if you could just briefly for the jury explain your understanding as far as some of the terms within those medical records. familiar with your review of Mr. O'Keefe's medical records that he was labeled as being in cardiac arrest?
Yes.
And can you explain to the jury what that means?
Yes, he was labeled as asystolic or in asystole, which is basically a flat line. So if you attach leads to the body, there is no electrical activity coming from the heart.
Now, with respect to Mr. O'Keefe, as far as certain vital signs were taken in the course of his treatment at the Good Samaritan, is that correct?
Yes,
Including a core temperature, is that correct?
yes,
Would you recall what that core temperature was?
yes. It was noted as 80.1.
And that was a temperature reading that was taken at 7:19 a.m., is that correct?
It was taken, actually, this temperature reading in the records that I'm looking at was taken at 6:57 a.m.
And with respect to that 80.1 degree temperature, that's in Fahrenheit, is that correct?
Yes.
And so what, if any, relationship does that have, or what, if any, relationship does that have to your hypothermic diagnosis?
Well, that is the temperature. At this point, Mr. O'Keefe is asystolic, meaning he has no cardiac activity. That is the temperature of his body at the time that he was taken to, that he was examined by EMS and taken to the hospital. So it is a very hypothermic temperature. It is well below the 95 degrees, which we consider hypothermia.
Now, I believe you alluded to it earlier in your testimony, but with respect to hypothermia, what are some of the manifestations of that type of onset as it progresses?
Well, the first evidence of hypothermia, which we have no problem in this room, is shivering. When someone starts to get cold, they start to shiver to conserve heat. But then as the body loses more and more heat, there are neurologic consequences. People can get confused. We see this in the elderly all the time. They can get disoriented. And eventually at very low temperatures, below 90 degrees, everything ceases to function. The heart stops.
And would physical weakness or lack of strength be one of those manifestations as well?
Yes.
And how many different sort of stages of hypothermia are there from the beginning of or onset of progression to the end?
There is mild hypothermia to extreme severe hypothermia.
I may have a moment, John.
Yes.
Now, with regards as far as the type of clothing that someone is wearing when they're outside in these types of conditions, what, if any, relationship would that have with regard to the quickness or the rapidity of the onset of hypothermia?
Clearly, the more layers someone has, the slower they will lose heat from their body. The fewer layers, the faster they can become hypothermic.
And what, if any, information did you have as far as how Mr. O'Keefe was dressed when he was found in the snow on the morning of the 29th?
The information that I was given stated that he was wearing a pair of jeans and a long sleeve shirt.
Now, with respect to someone as far as that hypothermia onset and the rapidity of it, what, if any, relationship would the condition of the clothing? What I'm asking there is more sort of the dryness versus wet clothing. What, if any, relationship with that?
Well, again, wet clothing or wet conditions will speed up the rate at which the body loses heat.
Now, lastly, with regard to this area, Doctor, in regard to Mr. O'Keefe having sort of alcohol on board in his system at the time that hypothermia onset, what, if any, relationship does that have in respect to the onset of hypothermia and the rapidity of that?
Alcohol intoxication, it has been shown to inhibit some of the mechanisms that the body uses to maintain heat. So it's definitely a factor that is a negative factor when it comes to hypothermia.
May I approach?
Yes.
Doctor, I'm showing you a single-page document. You could just review that, look up when you're finished. And do you
Yes.
recognize that, Doctor?
I do. It is a photocopy of the exam notes that I took at the time of autopsy.
Does that also contain a body diagram with relation to your notes as far as where you observed injuries on Mr. O'Keefe?
Yes.
Your Honor, may I approach?
Yes.
I'm off the seat to introduce him as the next exhibit.
No objection.
Thank you.
And Your Honor, with the court's permission, if we could publish that to the jury at this time.
Okay.
Doctor, there should be somewhere before you on the desk over there, laser pointer. Come in, if you could, enlarge that just a bit, and if you could focus in sort of the top and the head area. Now, Dr. Scortibello, what's up on the screen? Is that what you have before you as the next exhibit?
Yes.
And on this, as far as the examination that you conducted, that also included certain measurements as far as height, weight, things like that, that you did with regard to Mr. O'Keefe's body, correct?
Correct.
And if you could, what did you record as your measurements for both height and the weight of Mr. O'Keefe?
He was weighed by our staff as 216 pounds and measuring 73 inches, which is 6 feet 1 inch.
Now, Doctor, if you could, using the laser pointer before you, direct the jury's attention to starting with the front or the facial area and then to the back of the head, but just with reference to the head area, directing their attention to what, if anything, you observed in the area of the head of Mr. O'Keefe.
In terms of injuries,
Yes.
you'd like me to point out the injuries? So as I mentioned, there were ecchymosis, that's another word for collection of blood under the upper eyelids. On Mr. O'Keefe, the ecchymosis on the right eyelid was also associated with a very small laceration. Then there was an abrasion on the left side of the nose. And then on the back of the head, there was a 3-centimeter laceration. So this is the right side. It would be towards, the back lower side on the right side of the head.
And that laceration on the black lower side, right side of the head, is that in the same area that you observed what you described as sort of the originating skull fracture?
Yes, when the scalp was reflected, there was bleeding under the scalp in that particular area. And then when the skull was opened, that's the area that appeared fractured and appeared to have other fractures originating or radiating from it.
Ms. Gilman, if you wouldn't mind scrolling down just for the in the middle of the torso. And Dr. Scorbello, if you could again, using the laser pointer, just direct the jury's attention to what, if any, injuries you noted in this sort of middle torso or upper extremity portion of Ms. Rose.
So on the right upper extremity, and again, this is the back of the body. We have this collection of linear abrasions. I think the battery is dead. That measured up to 7 centimeters and extended from the upper arm down to the middle of the forearm.
If I could interrupt you for 1 second, may I?
Thanks. This would be the abrasions.
Ms. Gilman, if I could ask you to scroll down for the lower extremities. And again, Dr. Scorbello, if you could, again, using laser pointer, direct the jury's attention to what, if any, injuries you observed on the lower extremities in regard to Ms. Rose.
The lower extremities didn't have a lot of injuries. There was a small abrasion on his right knee area on the side. And if you don't mind pushing the diagram just a little bit more up to see the hands, there were some contusions or some bruises on the dorsal aspects of the right hand and some very faint bruise on the left.
Thank you, Doc. And Ms. Gilman, you can take that down. Nora, may I approach again?
Yes.
Doctor, if I could show you what's a 2-page document, ask you to just review that, look up when you finish.
Yes,
And do you recognize what that is?
I do.
And what do you recognize that to be?
These are copies of diagrams that I used at the time of autopsy to document some of the injuries on the face and the skull.
May I approach again, Your Honor?
Yes.
Home Health and seek to introduce in the minutes the next exhibit.
Any objection? No objection. Thank you.
Exhibit 644.
And Your Honor, may I return that to the witness?
Yes.
With the court's permission, if we could publish that for the jury.
Okay.
Ma'am, 1 moment, Your Honor.
Yep.
Again, Dr. Scorbello, do you recognize what's depicted up on the screen is the next exhibit before you?
Yes.
And if you could, again, using the laser pointer, direct the jury's attention to what, if anything, you observed or noted of significance in these particular diagrams.
So the upper eyelids, the areas of the upper eyelids on both sides had ecchymosis or blood under them. On the right side, there was a very small laceration or a small tear associated with that. Both eyes had some swelling to them. And then on the nose, there were 2 abrasions, 2 scrapes. One was small at 0.5 centimeters. The other one was 1 centimeter, and it was linear. And I noted them right there.
Come in, if you could scroll down a bit. And again, from the bottom right diagram for you, Doctor, if you could, use the laser pointer, direct the jury's attention to what, if any, injuries of significance you noted in that portion of the diagram.
This is the area where I noted the laceration to the scalp. I noted something called tissue bridging, which is a morphologic feature of of a laceration is what makes it different from an incised wound or from a cut, because again, the skin is crushed and now it's more irregular. The edges are more irregular. And then above that laceration, I noted that there was a scrape as well associated with it. So that was one injury.
In this moment, if I could have the next page of that. Doctor, if I could direct you to the next page of that exhibit before you. And Ms. Gilman, if you could, thank you, really sort of enlarge on the top left diagram.
Yes.
Now, Doctor, before we get into the diagram that's up on the screen, if I could ask just a bit more, if you could expound upon when you use the term ecchymosis, what exactly does that mean in specific reference to the area of the eyes?
Ecchymoses are a word that we use to describe bruising. Orbital ecchymosis or periorbital ecchymosis or supraorbital ecchymosis just refer to the location of the bleeding in relation to the eye. When we see ecchymosis or bleeding around the eyes, one of the differential diagnoses, one of the etiologies is blunt trauma to the head, and specifically fractures to what is known as the base of the skull. And this, what you're seeing here, is the base of the skull.
Now, Doctor, if you could, using that diagram up on the screen, explain to the jury, when we ask first, as far as were you able to formulate an opinion to a reasonable degree of medical certainty as to how the injuries within the skull and the brain interacted with each other? In particular, you interacted also with the ecchymosis that you're describing in the orbital region.
So the injuries inside the skull, this is the base of the skull. This is, think of it as the tray where the brain would be sitting on top. The brain has been removed, and now we're looking at the bones. Right here is where I noted the skull, one of the skull fractures to be originating or starting with fractures. These are linear fractures that are extending or radiating from this one point of impact. This is known as the posterior fossa of the base. These two chambers are known as the middle cranial fossa, and this area is known as the anterior cranial fossa. As you look at this, the eyes would be sitting back here. So the eyes are actually very intimately associated with the anterior cranial fossa, which is very thin, and the bones are quite thin and friable. So an impact to the back of the head as was in this case, because we do have a laceration and we do have an abrasion. So we know that the head impacted something blunt with enough force to break the skull and enough force for those fractures to propagate or radiate into the middle cranial fossa and also the anterior cranial fossa, which is the front chambers of the base. When the anterior cranial fossa are fractured, as I mentioned, they are very thin bones. Blood can seep from this area into the soft tissues and manifest as hemorrhage or bleeding or a contusion or an ecchymosis around the eye when you look at the person face, when you look at their face. So it is a well-known fact that fractures to the base of the skull can present with orbital ecchymosis, and that particular manifestation has a name. It's called raccoon eye because it resembles I guess, what raccoon eyes look like. But emergency room physicians are always very alerted to any hemorrhage and any bleeding around the eyes, because it could signify, or it could mean that there's a much bigger injury inside the skull, and that is not just some bleeding around the eyes, that it actually is associated with a skull fracture.
So the ethmosis itself, as far as the sort of drainage or seepage of blood, that's coming into, that's what causes the eyes to sort of swell up, is that correct?
Correct.
And Doctor, if I could ask you with reference to, if you could illustrate with the laser pointer on the diagram up on the screen, as far as the subarachnoid hemorrhage, subdural hematoma, as far as the bleeding within the brain, what, if any, impact that has on the skull as far as the fractures are concerned, or this building up of pressure itself?
The subarachnoid hemorrhage is a thin layer of hemorrhage on top of the brain, directly on top of the brain under the leptomeninges. The main effect, or I guess one of the effects that subarachnoid hemorrhage has, is that it is very irritating to the brain and can lead to seizures. Subdural hemorrhage is hemorrhage that is due to veins in the dura, that very tough protective cover on top of the brain, that are broken and leak blood into the space between the dura and the brain. That kind of injury, given enough time, you can have accumulation of the blood, and you can cause significant shift into the brain. That's not something that we had here. Here we had some subdural hemorrhage, but not enough that it was what we call space occupying, but it was present. So it was due to bridging veins in the dura being injured from the trauma, from the fractures. And in terms of the effect that all these injuries have, the subdural and the subarachnoid and the skull fractures, anytime the brain is injured, it responds by swelling. And the skull is a closed space without the ability to expand, unlike the skin, where you can have a bruise or a significant amount of blood accumulate under the skin. In the skull, once the brain starts to react to the injury and it starts to swell, there's nowhere to go except for down. And that's the foramen magnum. That is the area where the brainstem and the spinal cord will run out. You know, spinal cord connects, obviously, the brain to the rest of the body. And this is one of the few spaces that the brain can try and squeeze into, because he has nowhere else to go. So herniation, brain swelling and herniation are a general response that the brain has to any sort of trauma.
And Ms. Gilman, thank you very much. You can take that down as well, so we can have the lights back on. Now, may I approach Sister Retreat?
Yes.
Now, Doctor, with respect to the head injury, specifically the fracture, what, if any, opinion can you give or can you say in regard to the type of force or amount of force necessary to cause the fracture to the skull that you observed with regard to Mr. O'Keefe?
I can't really give you a number. I'm not a physicist. I can tell you that the skull is a pretty thick bone. It takes considerable amount of force to fracture the skull. So that was a pretty considerable impact.
Now, with respect to the injuries to Mr. O'Keefe's head and the onset of hypothermia, what, if any, opinion do you have with regard to the timing of those respective to each other?
Well, I do believe the injuries, the blunt impact injuries were sustained first. These are not injuries that are immediately lethal. This is not something that would cause death in seconds. And therefore, Mr. O'Keefe may have been incapacitated by the injuries or knocked out, if you will, and was not able to get himself into a warmer environment, and therefore hypothermia set in, given the environmental conditions and given the clothing on the body, or the lack of clothing, I should say, no big jacket or anything like that.
Now, when you say something as far as some type of injury being immediately lethal, can you give an example of that?
The one that forensic pathologists like to use is a gunshot wound to the head that goes from one side to the other, disrupting the neural systems of the brain and causing the person to immediately drop and die within seconds or milliseconds. This is not that kind of injury. This is an injury that took a little bit of time to develop, as is manifested by the fact that we have some bleeding, which means that the heart is still pumping and blood is still coming out of the vessels.
And so I guess to that point, as far as was it from your examination and your findings and your review of sort of the overall materials that leads you to believe that the head injuries happened prior to hypothermia setting in?
Again, the findings of hypothermia, the blunt impact injuries, if someone is, it's not completely out of the realm of possibility that someone becomes hypothermic and then falls as a result. But the hypothermia would continue along with the brain injuries that took some time to develop. So in my opinion, I believe the impact, the injury to the head came first. Mr. O'Keefe was most likely incapacitated or unable to move into a warmer environment, and then the hypothermia set in.
And if you can, what, if anything, can you say as to the sort of, in contrast to sort of the bullet to the head or the instantaneous death, what, if anything, can you say as to the time that this would take to manifest itself as far as the injury to the head and the hypothermic state?
Again, I can't give you specifics. I would say this was definitely in the matter of minutes, many minutes, or hours.
If I may have a moment, Your Honor.
Yes.
Now, Doctor, you had mentioned that at some point you had reviewed some photographs from the scene where Mr. O'Keefe's body was recovered. Is that correct?
Yes, I was shown some photographs.
And from the photographs that you were shown, what, if anything, of significance did you observe or lack thereof in the area where Mr. O'Keefe's body was recovered?
Well, based on those photographs, limited number of photographs that I saw and I was shown, there didn't appear to be a lot of disruption around the area where I was told that Mr. O'Keefe's body was found.
And that lack of sort of disruption in the snow around where Mr. O'Keefe's body was found, what, if any, significance would that have to you as far as from a diagnostic perspective?
Well, it suggests that he really didn't travel a very long distance once the injury was inflicted.
And as far as anything related to footprints, drag marks, anything like that, did you observe anything like that in that area?
On the pictures that I saw, no.
Now, from your extent of your examination of Mr. O'Keefe's body, what, if anything, that you observe that would indicate any sort of altercation or a fight or anything like that Mr. O'Keefe was in?
I didn't see any major signs of what I would call a significant altercation.
And with regard to that, as far as signs, what are some of the signs, and what would you be expecting to see, and what was lacking as far as your observations of Mr. O'Keefe?
I looked at Mr. O'Keefe's hands. As you saw on the diagrams, I did document that there were some contusions on the dorsal aspect, very vague and faint contusion on the left, and contusion on the right hand. That particular contusion has a central little pinpoint mark that may suggest that it was due to attempts to get IV access on his hand. That's a very common place. But I didn't see any bruising on Mr. O'Keefe's knuckles. His nails were intact. I didn't see any breaks on his nails, and I didn't see any fractures or feel any fractures on any of his hands.
Now, with respect to the diagrams that were up on the screen before, as well as your observations from internal examination, you observed some fractures to Mr. O'Keefe's ribs, is that correct?
Yes, he did have some fractures, I believe, to the 4th and 5th ribs near the sternum. It's a very common location for CPR-associated fractures.
And so I believe you just alluded to it right there, but as far as any fractures to Mr. O'Keefe's ribs, what, if any, opinion do you have as to the origination or causality of those rib fractures?
As I mentioned, those are very consistent with the resuscitation. We see those quite often. Given the history that I was provided, that extensive resuscitation was attempted, I documented those as most likely due to resuscitation.
Now, doctor, with regard to the, just by way of contrast, you talked a bit about the significant impact or the thickness of the skull. How does that relate to the area of the ribs that you're talking about as far as can be fractured in resuscitative efforts?
Well, I don't understand the question.
Let me rephrase it. What is the difference sort of between the thickness of the bone in the skull versus the thickness of the bone in the ribs?
The skull in general is a thicker bone. It requires more force.
Now, doctor, if I could, are you familiar with a medical term known as vasodilation?
Yes.
And can you explain what that term is and how it relates to Mr. O'Keefe's condition?
I can explain what the term is. Vasodilation means opening up. Vaso refers to blood vessels. So vasodilation is the opening up of blood vessels to bring more blood to the extremities or any part of the body.
And again, that's a bit of an unfair question as far as the relations, but so how does that manifest itself as far as someone who's in colder conditions or has that sort of onset of hypothermia? What, if any, relation does the vasodilation have to that?
Well, you can see vasodilation. You can see vasoconstriction and vasodilation in hypothermia. Initially, the blood vessels will constrict in an attempt to reduce blood flow to the extremities so there's no heat loss. Anyone who has Raynaud's knows what that feels like. But then ultimately the blood vessels will dilate, bringing more blood to the extremities. Again, the normal regulatory mechanisms that the brain has to maintain our body temperature are disrupted when you get into those very low temperatures. And therefore, sometimes in hypothermia, you can see very, very red extremities due to vasodilation.
And With regard to the redness due to vasodilation, is there also a whiteness, sort of discoloration to the extremities that can be observed in hypothermic patients as well?
That's been described as well, yes.
Now, with reference to when you make your observations of Mr. O'Keefe, why is it that, well, let me ask you this. You didn't see any signs of vasodilation or white fingertips or anything like that, is that correct?
Correct. I rarely see signs of vasodilation, especially if someone has died in the hospital.
And can you explain to the jury sort of why that is?
So for two reasons. In this particular reason, Mr. O'Keefe was taken to the hospital and attempts were made at rewarming the body. So he was given warm intravenous fluids and attempts were made to bring the body temperature up with the hope that the heart would start working once that happened. Also, I did not physically see the body until Monday morning. And therefore, I can't really comment on vasodilation or any effects that hypothermia may or may not have had acutely on the body, because I'm seeing the body hours after death, and already the body has been transferred from the scene to the hospital, stored at the hospital, and then transferred from the hospital to our facility. So there's just too much time between when the body was discovered to when I looked at the body to make any reasonable comments on whether there was vasodilation or not.
Mayor Pro Tem?
Yes.
Doctor, I'm showing you a series of 5 photographs. Ask you to review those with Dr. Finish.
I'm actually going to see counsel at sidebar for a minute, please.
Area, and having looked at the photographs, it makes sense that we break for today, and we'll start fresh with this tomorrow rather than showing these to you folks now. So, thank you. So we are going to end for today. We are on track. Maybe we are definitely on track for finishing this case next week, partly because of staying all day tomorrow and some of the work we did today, and on Tuesday when you all went here. So please follow the 3 instructions. Do not discuss this case with anyone. Don't do any independent research or investigation into the case. If you happen to see, hear, or read anything about the case, please disregard it. Let us know. We'll see you tomorrow morning. Thank you.
Sure, don't look on your chest, take all your belongings. All rise, jury open.
File out right after.
Thank you.